Okay, let's get started. Hello and welcome everybody to our satellite session at CUGH. This is sponsored by the American Academy of Pediatrics and the Coalition of Centers in Global Child Health. The AAP is a 67,000 member group of pediatricians and people who provide pediatric care that is dedicated to the health of all children. And the Coalition of Centers in Global Child Health is a network of expert individuals and academic centers and institutions that have explicitly expressed commitment to a collectively developed set of principles and plans of advancing global child health. So we're pleased that you're able to join us here today. So let's jump into our first panel. It's called The Policy and Practice Supporting Healthy Mental Development. And as you know, what we're talking about today is the right to be nurtured, the mental health of children in the time of COVID. Of course, many of the things we'll discuss today will be relevant to COVID, but also to how we buffer and protect children from other stressors in the world happening right now too. So this first panel lays the groundwork for a discussion on global mental health. Each of the speakers will present for approximately 7 minutes. And I'm just pleased that we have so many people joining us from around the globe. And I thank CUGH for the platform and the speakers for your time. So our first speaker is Dr. Tarun Dua, who is a pediatric neurologist with a specialization in health systems. She's currently head of the Brain Health Unit in the Department of Mental Health and Substance Use of the World Health Organization, headquarters in Geneva. This unit promotes optimal brain development, cognitive health, and well-being for all across the life course. Let's hear from Dr. Dua.
Hi, good morning, good afternoon, and good evening. My name is Tarun Dua. I'm head of the Brain Health Unit in the Department of Mental Health and Substance Use at World Health Organization. And it is my pleasure today to talk about mental and brain health of children in context of COVID-19, looking at the epidemiology and risk factors. As we have been going through this pandemic, we have realized that children are not the face of this pandemic, but they risk being among its biggest victims. All children of all ages and in all countries are being affected, but harmful effects they do not distribute equally. Children in poorest countries, children in poorest neighbors, and children who have been disadvantaged are affected more. The pandemic may represent only the tip of a mental health iceberg, an iceberg we have ignored for far too long in our policies, in our services, and especially for children and adolescents. What do we know about the numbers of children and adolescents who are being affected? When we look at younger children, we know that development lies on a spectrum. And even if a child has a developmental disorder, needs the importance of nurturing care so that the child can have optimal development. We know that majority of the mental disorders, they have their onset in adolescent period. It is estimated that more than 30% of adolescents aged 10 to 19 live with a diagnosed mental disorder. And if you look at these numbers, these are huge, 89 million boys and 77 million girls. Majority of these disorders, 40% are anxiety and depression, but there are a range of other disorders, like attention deficit hyperactivity disorder, conduct disorder, intellectual disability, eating disorders, autism, bipolar disorder, psychosis, and a group of personality disorder. And not only these disorders, they have a burden because of the morbidity. There is also economic cost. And it is estimated that the lost contribution to economies due to mental disorders among young people can be as high as $390 billion US dollars a year. When we look at the risk and protective factors, they act in three spheres. One, in the home, caregiving setting. The second is the environment in the school, communities, preschool, the safety, security measures that happen. And then, broadly, the social determinants, poverty, disaster, conflicts, and discrimination. Any of these risk factors or adverse childhood experiences, they can lead to long-lasting mental health problems or risky behaviors. It is estimated that exposure to at least 4 adverse childhood experiences is strongly associated with sexual risk-taking, mental health conditions, alcohol abuse. It is even more strongly associated with problematic drug use and interpersonal and self-directed violence. We are understanding the importance of social connectedness and more so in context of the COVID-19 pandemic and healthy lifestyle behaviors such as sleep, physical activity, which act as buffering factors against the deleterious effects of the pandemic on the mental health. It is clear that parenting is crucial to laying strong foundations for children's mental health and development, but many parents need more support and more so in the context of the pandemic. There are many reasons that COVID-19 pandemic has impacted children and their families. We have all read about the socio-economic impact, the increased family stress. In addition, impact that has happened due to mitigation measures put in place, for example, because of physical distancing, quarantine, which has led to social isolation, reduced social support. In addition, we have heard about disruption to services, essential health services, as well as the education and care services, and there has been a data that has been reported across the world. The pandemic has impacted caregiving. There have been reports of increasing caregiver stress and also sometimes impacting the closeness, leading to harsher parenting attitudes and increased parent-child conflict. Let us also not forget the number of children who have lost their caregivers. There have been reports of millions of children losing their primary caregivers, and they need care and safe, stable, and nurturing families, along with economic support, quality childcare, and evidence-based parenting support. There have been also reports emerging that children who have been born during the COVID-19 pandemic, and I'm not talking about if there has been maternal SARS-CoV-2 infection, but otherwise, and we are seeing differences in neurodevelopment at age 6 months. And these children having reduced verbal, motor, and overall cognitive performance compared to children who are pre-pandemic. These are emerging reports and more research is required in this field. A recent scientific brief on mental health published from WHO showed that there is elevated level of depression and anxiety, especially in older children and adolescents. A meeting of 19% of 15 to 24-year-olds in 21 countries self-reported in the first half of 2020 that they often feel depressed or have little interest in doing things. There have been reports about increased suicidal behaviors, but there is inconsistent global evidence. A few countries have suggested that, and strong evidence is in Japan that we have seen of increased suicidal behaviors. Clearly an area where more research is needed. To summarize, when we ignore the mental health of children, we undercut their capacity to learn, work, build meaningful relationships, and contribute to the world. Action is needed in both service delivery and research. We need to integrate child developmental outcomes in all the COVID-19 research that is happening to better understand what is the long-term impact of this experiment of nature. A multi-sectoral approach is required. Health sector, education sector, child protection, and with special attention to the most vulnerable. For example, children with developmental disabilities. Clearly, we need to better listen to families and caregivers, and at the same time,
I think we had a little break in the connection there, so we're going to move on to Laila Saudi. Dr. Saudi is the founder of the Stanford Med MENA Health Program, which is focused on building research implementation and capacity across the Middle East and the North Africa region. She's also the founder and former lead of the Stanford Refugee Research Project, a project to explore how Stanford University can best engage to address the refugee crisis in the Middle East. We look forward to hearing the wise words of Dr. Saudi. Over to you.
Perfect. No pressure on it being wise words. All right, can everybody see this okay? Perfect. All right, so hi everybody. Our work at Stanford Med really focuses more broadly on sort of leveraging what Stanford is really good at in terms of like healthcare, research, education, training across the Middle East. But I wanted to really focus on sort of some of our core programming as it relates to child refugees. So I know that, and I'm super excited about this. I know that we'll personally hear from some of my friends who have gone either through displacement personally or who are humanitarian workers. So really, I don't have much to say about this, but I really just wanted to set the stage. So if we think about context, we have on the order of 82.4 million people who have been forcibly displaced. This is a massive sort of understatement or underestimate. This is sort of by the end of 2020. We don't really have super new numbers. And of course, this doesn't take into account the ongoing Ukraine crisis, right? But say it's on the order of around 90 million. I want you to sort of really understand that about half of these are children, right? So if we think about, these are some statistics about sort of where they're hosted, what percent of the population it is. But what I really wanted to convey in this is that most people, so if we can see here, around 80% of the world's displaced are in countries or territories affected by acute food insecurity and malnutrition, right? And most people who are displaced, be it internally displaced, so they stay in their same country. So say, for example, in Syria, but they remain within Syria, but a different location, or if they're refugees, meaning they've crossed an internationally recognized border, but they stay in developing countries, right? So in thinking about sort of how we create a safe environment, there are factors that prevent us really from being able to do so well, right? And those just come by sheer numbers. So if we think about like how many people who are displaced in the world, how many of those are refugees, how many of those are children and most vulnerable. Also a harsh reality is that they're often excluded in countries of asylum, right? With a denial of rights in terms of access to proper healthcare, proper food, legal protection, etc. What also really sort of impacts our ability as humanitarian workers to build a system that is that sort of better preserves the human dignity is that most of these crises ended up being protracted situations, right? So it's not on the order, as we can see here, for example, by what's happening in Ukraine, is upwards of around 3 million refugees in a span of 3 weeks, right? In most situations, say, think about the Syrian refugee crisis, it's been on the order of 11 years, right? They're still refugees, they're still excluded in countries of asylum, there's still an active denial of human rights. What happens in these protracted situations is that there's sort of fatigue and there's decreased funding, right? And there's a lack of responsibility sharing system. So on behalf of sort of, donor countries, on behalf of countries where they've been resettled, who really sort of takes ownership and who really then, whose responsibility really is it to sort of uphold the human dignity of refugees, and specific, say, child refugees. So what happens is some sort of responsibility by proximity and often a second exile. All of this really manifests, I think, the key point in a lot of structural violence factors. So often when we think about mental health and how do we create a safe space, it's almost like we talk about it as a separate entity. Like we have to do more to ensure that, depression, PTSD or trauma-based or anxiety rates are lower, right? But it's hard to tease that apart from some of the other structural violence factors that perpetuate these mental health symptoms. So I think one of the key things that I really wanted to touch upon is the main factor that globally sort of prevents us from creating these safe spaces for children to secure sort of better mental health is the fact that we don't often address the underlying factors that actually enable these mental health symptoms to go on, right? So it's not just exposure to war. It's the fact that you think about, for example, and these are only exacerbated during COVID. We think about the fact that most folks who are displaced don't have access to proper education, especially made worse like with technology and remote learning, for example, in refugee camps during COVID, and less than 1% make it to college, right? There's not sufficient access to employment opportunities. So most people end up living really either through debt or they make it on a few dollars a day. Mental health symptoms don't often exist sort of just, I have depression or I have anxiety. They also often come with these comorbid realities, right? So a lot of people struggle with, various sort of NCDs most often, so hypertension, diabetes, etc., low access to care broadly. There's also a lot of water, sanitation, and hygiene issues. One massive thing that I think got a lot worse during COVID also is food insecurity. So we in sort of legal protection in various host countries. The other one being poor housing, of course, which is that the vast majority of refugees live in these sort of precarious conditions. For example, in Jordan, where I am now, upwards of 500,000 people still live in tents to this day, even though it's been, for example, 11 years since the Syrian war. So the main message here is when we think about how do we create better situations or better realities for child refugees, for example, or children who are displaced, we can no longer stop. We can no longer just continue to think about access to mental health care separately. We have to think about it in the broader context of how do we prevent some of these structural violence or alleviate some of these structural violence factors. The second key point, I think, in thinking just about mental health is that there's a high burden. So to this day, for example, let's think about Jordan, just because I'm here, there's upwards of the prevalence of depression, anxiety, and trauma is upwards of 65% in the communities where I work, in the refugee context where I work. And what sort of enables those factors to happen is that there's very few mental health professionals. So in Jordan, that's home for, say, like 10 million people, 4.5 million of whom are refugees. There's on the order of 300 mental health professionals. That's psychiatrists and clinical psychologists together. And even if we think about those, the cost is really high, right? Between transportation and actual access to care, especially considering the low employment rate that I mentioned, right? So I think the second key part here is in thinking about, well, what can we really do about it? How do we sort of enable access to better safe spaces? Is we have to start leveraging more community-based mental health service delivery. So we can no longer really just rely in terms of global mental health. We can no longer just continue to rely on the few specialists that we have, but we have to large scale deploy sort of community-based mental health interventions where we take, for example, women from the community, train them on a mental health approach, supervise them, of course, have them serve as first line counselors to members of their own community, and then only use sort of these few available specialists in really severe cases where, as a child refugee, for example, expresses sort of, suicidality, etc. So I think it's important to consider that there are factors that are preventing us from sort of, creating these safe environments, but there are very much things that we can do. It's just that one step to get there is that we can't really think about mental health as a separate issue. And then the second consideration is that we have to use the resources that we do have that are very much available in the community to ensure that, the people who are responding first and foremost to these mental health symptoms are very much within the community, aware of their circumstances, and then referring out only in severe cases. Thank you.
Thank you so much. Next, we have Dr. Pamela Collins Dr. Collins is a professor of psychiatry and behavioral sciences and professor of global health at the University of Washington. She's the executive director of ITech and director of the UW Consortium for Global Mental Health. She's a psychiatrist and mixed methods researcher with 25 years of experience in global health and mental health research, education, capacity building, and science policy leadership. Her research and public health practice activities support the integration of HIV and mental health and assess the mental health needs of adolescents in cities around the world. Over to you, Dr. Collins. And please, if you have questions, please put them in the chat, and we will get to that in the Q&A session when all the speakers are finished.
Hi, everyone. It's nice to be here. Thank you so much for the introduction. I'm going to share my screen. Okay, I'm going to talk today about adolescents and their mental health and how we can think about that in the context of cities. And specifically, I'm going to pick up on some of the themes that our last speaker just touched on, but specifically, in order to move this agenda to getting more attention to mental health going worldwide, how do we actually join forces with other agendas that are important for our health and well-being globally? So to start, approximately 55% of the global population lives in cities. That means around 1 in 8 urban residents lives in a city, actually with more than 10 million people. By 2050, it's estimated that 66% of the global population will reside in cities, and that will account for about 70% of the world's children. So cities offer a lot of great resources. They offer greater opportunities for wealth, for employment, for social freedoms, and education, but inequality is increasingly one of the hallmarks of large cities in high-income, middle-income, and low-income countries. Children under the age of 25 are the most likely demographic to seek out education and employment opportunities by moving to cities. And in fact, young people are about 40% more likely than older generations to migrate from rural to urban areas. In the context of COVID, we learned quite a lot about city life because smaller epidemics were incredibly powerfully felt in cities around the world. And here are some reflections from a World Bank paper that highlights what mayors in cities around the world noted. And I'll just read these briefly. One of the biggest lessons learned from the COVID-19 crisis is that sustainable, resilient cities were able to handle the pandemic better. What COVID-19 did was to make the problems faced by cities visible to those who are not working in local governments. And finally, if urban areas are where COVID-19 impacts have been the most severe, it also means that interventions in cities and towns can have the biggest impact. So when we think about adolescents specifically, there are around 1.2 billion adolescents living in the world right now. They're about 16% of the global population. The majority of adolescents live in Asia, and they account for approximately 23% of Africa's population. And Africa and Asia are where 90% of urban growth is expected over the next decade. What do we understand about urban environments and mental health? Much of the research that has been done over many decades, and even, I dare say, centuries, shows that urbanicity increases the risk for psychosis, for anxiety disorders, and depression. And much of this can be attributed to social factors, social isolation, neighborhood poverty or violence, and discrimination, which contribute to poor mental health in these contexts. But despite the fact that urbanicity and these factors in urban environments play an influential role on mental health, and despite, as we learned from the very first presentation by Dr. Dua, despite this high prevalence of mental health conditions among young people and these factors, most countries have insufficient investment in youth mental health. So it's clear that we need a broader advocacy to change this. Joining forces with groups that are promoting urban sustainability is one way to do this. So many of you may or may not be aware that the United Nations new urban agenda was adopted in Ecuador in 2016 at the Conference on Housing and Sustainable Development. And the agenda writers have a beautiful vision. They envisioned a future for cities in which all city dwellers without discrimination of any kind, are able to inhabit and produce just, safe, healthy, and accessible, affordable, resilient, and sustainable cities and human settlements to foster prosperity and quality of life for everyone. So here are some of the principles of that agenda: leaving no one behind by ending poverty, ensuring sustainable and inclusive urban economies, ensuring environmental sustainability, including adopting healthy lifestyles in harmony with nature. And what I want to highlight for the rest of this talk is that full implementation of the new urban agenda could actually reduce some of the upstream risk factors for poor mental health for young people. I'm going to talk about this by framing it in terms of a framework that many may be familiar with, that Jeremy Schiffman and Stephanie Smith have proposed. And what they've posited is that if we can raise the profile of activities in global health generally by focusing on four main factors. So I'm going to say that if we can raise the profile of activities relevant to urban mental health, we can use these foundational factors to also advocate for better urban environments. And so the first is how we frame ideas so that they resonate with decision makers. An example of an internal framing, which is the way that we as members of the mental health community, members of the global health community think about adolescent health. The way that we frame adolescent mental health is that adolescence is a dynamic period of neurodevelopment. Young people acquire their cognitive, emotional, social skills for expanded interactions beyond home and family during this time, and their interactions with the physical environment are central to their well-being. We could also then begin to think about how to frame this for urban designers, right? This framing could center on the urban public realm, meeting the needs for adolescents, meaning how can the use of streets, public spaces, footpaths, walkability of neighborhoods, how can all of these influence mental health? And in fact, we know quite well that being in the public realm for young people, being in green spaces can evoke better mental health by renewing depleted attention, by reducing the stress of cognitive overload from urban living. We also know that policy and community supports for adolescent mental health can be implemented even before one can eradicate poverty. So social protection policies that reduce maltreatment and improve parental caregiving, community structures that permit quality peer relationships can support children in adversity, cultivating friendly home environments and supporting parental monitoring and presence in the home, community design that enhances neighborhood social support, and also creating locally accessible economic opportunities for adult female carers. These are based on data from South Africa, from Kenya, from India, that have begun to show that these are routes toward mental health for young people. We also have to think about the characteristics of an issue when we want to advocate for it. How severe is the issue? Are there credible indicators for it? Are there effective solutions? And this is a snapshot of what does the prevalence of mental disorders look like in, these are 6 Asia Pacific countries, showing that when we look at children by the age of 15 to 19, adolescents, there's a significant prevalence of mental disorders that ranges from 14 to 21%. So this is data that shows that this is a serious issue, and we do have data, as we've heard, showing that we have effective interventions. All of these together help to define the issue. Actor power, the ideas and the evidence and the framing of adolescent mental health need to be conveyed by an influential group of actors and institutions. Researchers, multilateral organizations, advocates, policymakers can all advocate for the shared interests of cities and adolescents. Importantly, this community of people advocating for mental health is continuing to grow and getting more diverse. Youth advocates, including youth with lived experience of mental health conditions, are incredibly important members of this advocacy community, and the global mental health community, as well as the child and adolescent advocates, need to begin to learn the language of urban sustainability in order to advocate for better cities that support mental health. And finally, one route to political priority is to take advantage of policy windows, that is, political moments that present opportunities where advocates can really influence decision makers. An example of that is achievement of the sustainability goals, especially goals 3, 11, and 13 for health and well-being, sustainable cities, and climate action. And of course, youth-led movements for climate, racial justice, I think show us how this can be done with young people at the center. And these also have very clear pathways to integrate mental health messages. And I'm just going to conclude by reminding us that cities provide a powerful opportunity to shape and support adolescent mental health. To do this requires collaborative efforts involving new sectors and new partners. Communicating ideas and actions relevant to new partners is critical for prioritization, and adolescents, of course, can play a central role in this advocacy. So thank you.
Thank you very much, Dr. Collins. Finally, our speaker for this session is Dr. Mariah Ramandar. She is a pediatrician and adolescent medicine specialist in the Division of Adolescent and Young Adult Medicine at Lurie Children's Hospital in Chicago, and an assistant professor of pediatrics at Northwestern University School of Medicine. Dr. Ramandar serves as the medical director for the Substance Use and Prevention Program. Her clinical research, teaching, and advocacy interests include adolescent substance use, mental health, and long-acting birth control. Over to you, Dr. Ramandar.
Thank you. All right, I will share my screen. Okay, so thank you all for having me. I will go through this fairly quickly, I'm looking forward to time for questions and discussion as a panel. So I was asked to speak on preserving healthy adolescence, specifically in females, but I really think that this can translate to any gender. I wanted to show this image. It felt like a nice way to think through elements that really promote health and wellness. We know that there's a bare minimum that people need to have access to food, clothing, shelter, things like that in order to survive. But in order to thrive and in order to be well and healthy, there are other aspects of life that are important to foster. So including emotional wellness, intellectual stimulation, financial stability and thriving, social connection, spirituality, and not necessarily religion or, but really kind of can be religion, can be spiritual, but can be really what is your purpose and what is the youth's purpose for going through life. Environmental safety and climate, I think, would fit into there. Physical well-being, so healthy eating and access to safe activities. These are components that are critical to promoting health and wellness in youth. So some steps and some key areas I think that could be helpful in making a difference in care of our youth in the US and abroad is breaking down these siloed care. So integrating care into different settings. So oftentimes medical care is separate from mental health care, and somehow mental health care is separate from eating disorder care or substance use treatment. And but really by separating these, that's just not how humans experience life. These are often commingled, impact each other. And we know that accessing this care can be really difficult for people. And if, really thinking of how we can provide care to people in different settings can be helpful, and really seeing how these things feed into each other, particular with substance use. For youth that have substance use disorders, the majority of them also have co-occurring mental health conditions. So if we treat them separately, we're not treating the whole person. And there could be different reasons that people access care, and where our priorities may be different than the youth. Being able to address them and kind of engage in care where the youth is interested can get the conversation started to really start chipping away at other issues that we may see as more pressing. Okay. Expanding access is critical, and where borders shouldn't be barriers to care. We saw telemedicine revolution is maybe one of the only upsides to this pandemic, is that been able to reach people who couldn't traditionally access care within the walls of our clinics, and been able to follow up with people in between visits, for youth who are engaged in college, not having to change care during a really, young adulthood is such a tricky time for people. And we see decreased outcomes in terms of physical and mental health during that time. And so being able to have continuity of care is important. You know, but the issue is that, rules around confidential care, rules around what youth can access differs by US states and by countries. So that can make it tricky providing care across different borders. And so really hope that what happened during the pandemic and increasing access to care through telemedicine could improve, could continue, and we could really improve how we reach people. But we still have to be creative and continue to work on decreasing barriers, because we still saw that the people who had issues with technology access, with being able to even access, telemedicine services, are the people who were already disadvantaged from accessing traditional medical and mental health care. Getting rid of stigma is also so important. We know that mental health conditions, substance use conditions are so stigmatized. People, other people judge people for having these conditions. Sometimes, particularly around substance use, it's still certainly considered like a moral failing. And though we've tried to change, the perception of mental health conditions is not something that somebody chooses or, may have some agency in getting treatment for, but the judgment from others, the internal shame from having some of these conditions can really limit people in accessing care, continuing to get evidence-based treatment. And there is still certainly a ton of stigma around accessing evidence-based treatment and medications, where, people still think of we're trading one drug for another if you're treating opioid use disorder with, an opioid medication, or, or treating mental health conditions with SSRIs. It seems pretty commonplace in certain areas, but there's still a ton of stigma. And though we have seen that all youth could really benefit from expanding access to treatment, we need a huge workforce boost in order for people to have access to care. Reaching people in different care settings is critical. But we really need to pay particular attention to those disproportionately impacted by lack of access to care and other obstacles that come their way. And people that stick out in my work would be racial and ethnically minoritized youth and sexual and gender minoritized youth. I wanted to share a couple of resources in conclusion that may be helpful in promoting wellness of our youth, and these are through the AAP healthychildren.org website, some handouts on adolescent depression and how parents can intervene, building healthy self-esteem in teens, talking about drug use, and then a couple on eating disorders. And there's a wealth of resources there as well that are freely available. Thank you.
Thank you so much, Dr. Amandar. I'd like to invite all of the panelists back for a quick Q&A session. And I think I'm going to start with you, Dr. Amandar. You talked a bit about silos of care, and several people have talked about the silos between mental health and other aspects of healthcare. But there's another silo, and that's between adult and pediatric care. And 2 years into this pandemic, many adults particularly those who have worked through the pandemic, are showing compassion fatigue. Their health is suffering. And I just wonder, what are you seeing in terms of how this has impacted children and getting their needs met?
Gosh, that's really, this pandemic has been hard on everybody. And, the people taking care of youth are humans too. And it has been hard and draining to see all of my teenagers and young adults coming to me so miserable. And sometimes it feels like, what can I even do to help this situation? I really try to practice self-care outside of, the clinical visits I have. But then in the visits, looking for those positive changes, looking for, really celebrating positive changes in people's lives, and just stepping back and realizing we are making a difference. We can and need to keep working, fighting, and advocating. But it is hard because there's still hope, but you feel like hope has been dashed many times over. I don't have the answer, but just keep going, keep fighting. I think we can keep making differences.
Yeah. I think that hope can be particularly hard to capture in settings like IDP settings and camp settings. Dr. Saudi, what are you seeing in Jordan in terms of the impact of adults' mental health on children?
Yeah. I would say at this point, luckily, I think two years into it at this point, which is crazy to think about. I feel like the rates of depression, anxiety, PTSD related are starting to decrease slightly. I feel like people are everything that sort of normalizes mental health, good mental health, is back in place pretty much, right? Aside from the massive structural violence factors, but I mean, more people go to school these days. There's slightly more employment opportunities. So all in all, I would say, yeah, it's hard to capture hope, right? And there's always more room for it. But I would say that compared to, say, 2 years ago, a year and a half ago, we're in a better place today. And the other factor is, no matter where we are, we can't sort of underestimate the resilience amongst kids. So what I've personally been able to witness is just how wonderfully resilient, and not that it's on adults to make sure that we don't just have to rely on the kids' resilience, right? But it's been amazing to just see sort of what, the kids I work with have relatively no access to anything, but then have makeshift toys and are jumping around and playing. And so even though it's been hard, there's still a prevailing sense of hope and resilience.
That's good to see that starting to turn the corner a little bit. So, Dr. Collins, there was a report that was released by WHO showing a 25% increase in anxiety and depression during this pandemic. And of course, this coincides with disruption in mental health services, as I'm sure you have seen yourself. Can you give us some advice about how we can ensure as providers that our institutions and governments continue to find ways to prioritize mental health, even in these times of crisis?
That's a great question. I think that one of the, I don't know if you can say one of the perhaps blessings of this pandemic is that people have recognized the importance of mental health. I mean, if you look at this country, the Surgeon General's report identified that we're in the midst of a public mental health crisis for young people. So I think part of what we're seeing through the full emergency rooms, through young people on social media, through parents, through providers, dealing with their exhaustion on the front line, is that mental health has actually gained some sort of priority. I mean, this is an example of one of the policy windows that I talked about, right? A context in which we've been able to spotlight some importance of the issue. The question is, how do you keep that momentum going, and how do you use this momentum to be able to advocate for more resources? I think that's one of the challenges. More resources that will continue during the post-COVID, or as we stabilize a bit and the intensity of the epidemic winds down. I think that requires parents, providers, all of us, the kinds of people like us and the kinds of people that utilize our services, as well as I was pointing out, other sectors, people in education, people in housing need to also be able to join us in that advocacy to our cities and to our federal governments for greater resources. I wish I had a better answer than that, but I do think that it really means demonstrating the evidence and using that evidence to advocate.
Yeah, great advice. That persistence, I'm sure. Well, I want to thank all of our speakers. This has been a really rich session. We're going to go ahead and take a 5-minute break now, and we'll come back and hear directly from some youth with lived experience and who are active advocates as well. So take a break, give a little stretch, and come join us at 51 minutes past the hour. Okay, thanks. Called mental health IRL in real life experiences of youth. So we'll feature 5 young people who have lived experience in mental health or are experts and advocates in mental health, and they'll bring life to the gaps in addressing mental health. Our first speaker is Grace Gatera. Grace is a lived experience mental health advocate in Kigali, Rwanda. She is a welcome lived experience advisor, a young leader with UNICEF Leading Minds, and a young leader with My Mind, Our Humanity. Grace has a degree in mass communications from Uganda Christian University. I think you'll see that she is passionate about young people's access to specialized and quality mental health care and medication. Over to you, Grace.
Hello, I'm extremely excited to be here. Like Jana very kindly said, my name is Grace Gatera. I am a lived experience advocate living in Kigali in Rwanda, and I am very passionate about mental health. So I advocate from lived experience, and I have lived experience of many things, unfortunately, but some of them include PTSD and depression and panic disorder. I am in recovery at the moment, but for panic disorder, but I've lived with it for most of my life. And the reason I have all of that is because I'm a former refugee. I lived in Uganda because my family and I fled from the 1994 genocide against the Tutsi. Unfortunately, my parents as well are, second generation refugees, and that has definitely played a part in how I grew up. And so, yeah, so the thing about mental health, the thing about gaps in mental health is living in the country that I do and having the conditions that I have. I've learned a lot about mental health care. I've learned a lot about access to mental health care for people with lived experience as well as for young people. So one of the things that I've learned from seeking care and from supporting other people who seek care is that there's very little push to specialize mental health care for young people, and to make it so that young people can access it and can have access to people who specifically are there for them. And in some ways, this can be because of negligence or because people are not taking care, but sometimes it's being underfunded. Another thing that I've noticed in the gaps is that there's so many gaps. There's economic gaps, there's societal gaps, there's a lack of presence of young people in spaces that should be for young people. But social media has made that clear, that people are speaking, that young people are speaking, that young people want to get involved, but there is very little representation for young people and for people with lived experience in all areas. How can this change? We have to work together. I've been speaking about this for 3 years now. I joined the global mental health space 3 years ago. And even before that, I was working with people like me, repatriated refugees, young people who grew up here, people who've experienced the war, and girls who are currently experiencing mental health challenges from GBV cases. And I think that, simply put, it's always been, our wish has always been, listen to us because we are speaking. It has never been about, we want to take over, we want to dominate, we want only our wishes to be true. But there's been very little participation. There's been very little looking for people with lived experience and young people. And I think it's time. I think that we can always talk about this, but there has to be an equal exchange and equal participation if things are to be taken seriously. My call is, please do not discount youth. They may have fewer years than normal, fewer years of existence, but I feel like, especially given the COVID situation, that we've garnered so much experience. We've had to deal with so much. And as a former refugee, I think a big part of the things that I've seen out there has been this feeling that, this is happening again, that we are going through the same challenges, that it was not enough to go through the genocide. It was not enough to have challenges, mental health challenges going on, but the COVID situation brought back the importance of involving young people because they are experiencing this in real time.
Absolutely. Thank you so much, Grace. I really appreciate that. And we hear you. We're here and we're listening. I'd like to invite Farah Khalek next. Farah is the founder of the Farah Foundation, which is based in Nairobi, Kenya, and aims to spread awareness about, advocate for, and empower people living with autoimmune and chronic diseases. Farah, as a brand, champions positivity, self-love, confidence, and inner strength. Surviving scleroderma through an ongoing stem cell treatment, she believes in making the most out of every situation and her promise to herself to live her best life. Farah is a motivational speaker and a strong advocate for a positive body image through self-appreciation and self-acceptance. She shared her story in various published articles and broadcast media and has spoken at events and is an ardent digital creator who shines on both sides of the lens. Farah is exploring her writing passion and has committed herself to write her first book. Yay! Passionate about life, she tries to inspire life each day. Over to you, Farah.
Thank you so much. I am extremely honored to be speaking today. I am surviving scleroderma through an ongoing stem cell treatment. This is an autoimmune disorder, and it has basically changed me. My very first symptoms came across when I was about 18 years of age, and I was a young girl, a teenager, just about, getting ready to become a woman and see my beauty blossom, trying to figure out life. And it was at that time my body started to change. I did not know what was happening with me. There was not much information about scleroderma in where I live and generally across the globe. There was a lot of misdiagnosis with my condition. I had to for about 2 years not knowing what was happening to me. So my body was changing, number one. I'd like you to picture this because this was my journey, and we're gonna go through this together. So yeah, picture yourself 18 years of age. You don't know, you're ready for life, and all of a sudden you have these weird symptoms. Each day you wake up, you're slowing down, your body is changing, literally. Your physical appearance is changing. Doctors don't know what is happening with you. Your family is worried, but they are being strong. They're telling you, it's okay, it's okay. But in real sense, they don't know what's happening. No one knows. We don't understand, the doctors don't know. And 2 years of confusion, agony, that was me. After that, I was correctly diagnosed with scleroderma, but the damage was already done. My physical appearance had already changed. At this point, I used to look at the mirror and be really scared because I thought I used to see a monster. This was not the person that I was. Where is Farah? And so 7 years after that, I lived in darkness, in bitterness, in negativity, in frustration, in agony, in pain, in hatred for myself, in hatred for everything around me, in hatred for God, for creating me, stuff a lot. But yes, that was me. And subhanallah, I slowly learned to accept myself. It was not easy, and it's still not easy today. I'm not saying that today I wake up every day, all happy and jolly. No, I do have my bad days. I'm human. And so I try to teach myself how to love myself each day. I tell myself I have to appreciate you. I appreciate myself, even if it's just being able to brush my teeth in the morning. I jump up in joy and I tell myself, you did it. You did something today. And so this is my journey. I'm trying to be very quick. But yes, this is my journey. I still go through it every single day. There's not a day that passes that I don't embark on this journey of self-love, self-appreciation, self-acceptance. Because every day I look into the mirror and I have to tell this girl that I love her and that she has to live her best life and that she will. And I know I can and I know I will. And yeah, I am grateful that I have reconnected with my God as well. So spiritually, alhamdulillah, I am very strong now, and I believe that has given me more strength to be who I am today and to carry on with my message. And I'm very passionate. I just want to add, I'm very passionate about spreading awareness on autoimmune and chronic diseases. Thank you so much.
Thank you. Thank you for your courage and your bravery. And we're so glad that you're here.
Thank you.
Next, I would like to go to Abdulaziz Dukan. Abdulaziz is a photographer with Through Refugee Eyes and a student at Regia Universiteit Brussels. He is originally from Homs, Syria, and has lived in Turkey, Greece, and now Belgium after leaving his country in 2014. Please tell us a bit about your journey, Abdulaziz.
Can you hear me first?
Yes.
Okay.
That's good.
Hello, everyone. I'm glad to be here, first of all. It's actually a pleasure. It's actually a pleasure for me to be here. To talk about mental health is actually not an easy thing. I think we've had that a lot through the journey because the way that things change, the way that things flip out actually is really weird and very fast. I lived in Turkey for almost a year and a half, and I left from Turkey to Greece. And I lived in a refugee camp for actually 6 months. And the time I was actually there, it's to see the people going through things, and the waiting process has been very hard for a lot of people. But the thing is, mental health in Syria, for example, is not, it's not as it's not important, but it's a bit of, it's always more taken as the person who's going, for example, to a psychologist is more considered as he's crazy. So actually the way of looking at it is not as advanced, or is not as truthful as it should be. And that's one of the problems, because a lot of people used not to accept what they're going through, because actually they would think it's shame if they will go and find out a bit more what's happening with them through a psychologist or something. This was actually hard. This was one very hard thing, because a lot of us, if we have troubles, we're not going to go to a psychologist, for example, but we're going to turn into faith, into saying maybe it's just if I have more faith, I'm just going to solve my problem, which works perfectly. But sometimes to have some specialists is very important. Now there's one thing that I know, and I know it's always important. A lot of us who came from war zones, or been in war zones, actually, have seen a lot through our journey and through what's happening in Syria. We're more considered as well once we arrive to the countries where we're at. Like I live in Belgium today, and I know for a lot of people, they're always scared to talk about specific things with me, like war or like what happened back there. It's more considered always like as people would have some trauma or some psychological problems, so they're not going to talk about specific topics, which is not actually very also true. Because in COVID, for example, a lot of refugees around me, including myself, it was not as hard as it should be. Like it was not actually a very hard situation, because honestly, we've been somewhere isolated. We've been in Syria, we've been isolated, we've been without a lot of things we didn't have in COVID. Despite in COVID, we have electricity, water, and all of that. But there we don't have internet, but actually we don't have a lot of access to other stuff. So in that case, I've seen a lot of refugees, Syrians actually, who have been doing a lot better than my Belgian friends, who were actually really suffering from very harsh psychological kind of conditions, because there's no parties, or there's no clubs, and there's no friends and all of that. So it was very important actually to notice that. I think for me it was really interesting, because we're not as they make us, like it's not as it's made to seem, as we will always have some kind of psychological problems and just have like post PTSD. I think it's like post trauma and PTSD, or all of the other kind of psychological troubles. So I think it's very important. But again, until up to now, I have even myself been always going through the process of, hey, look, if somebody's going to a psychologist, it's needed. It's not like they have some problems. No, it's a natural process. So even me, I had to go through the fact that saying like, hey, no, maybe I was raised there to a different kind of psychology, because actually also 10 years ago, we weren't as advanced as now. But with time, I think I've learned that, and a lot of people today actually learned that. And I know a lot of people around me who actually had to follow up for a bit, and it actually helped. So I think, I think now education and awareness is getting better. That's it.
Thank you so much, Abdulaziz. I think it's important for everyone to remember that each journey is unique, and we're glad to hear yours.
Thank you.
Next, I'd like to introduce you to Maddie Williamson. Maddie is a registered nurse from Seattle, Washington, who specializes in migratory health. She holds an associate's degree in nursing and a bachelor's degree in public health, and has spent 5 years working with refugee populations in the Middle East and Mediterranean region. Her focus is on promoting human-centered design models for health and development interventions in displacement settings. And she's currently part of a research team at William and Mary College studying moral injury in humanitarian workers. Let's hear a bit from you, Maddie.
Hi, you guys. Hopefully everyone can hear me okay. I just want to first and foremost thank you guys for organizing this, and thank the speakers who just shared their personal experience. Abdulaziz is a good friend of mine, and I think he brought up a really important point that I want to emphasize about how we can't make assumptions about people's own health beliefs when it comes to their mental health and actually seeking that care. I think that's something really important for us to remember when we're talking to anybody, whether we're practitioners and we're speaking to a patient, or we're just trying to be a supportive friend. We can't make assumptions or put the words in people's mouths about their health beliefs. And so what I'm going to be talking about a bit is from the provider perspective. So as mentioned, I am a registered nurse. I work in migratory and refugee health. I'm also going to be reading today because healthcare providers have one brain cell left at the moment, and mine is really tired. So like many healthcare workers, I am currently suffering from clinical burnout, lots of post-traumatic stress disorder, and moral injury. This pandemic has made our jobs as healthcare providers infinitely more complex. We've witnessed needless suffering. We've been asked to sacrifice so much of our own lives to uphold these promises and oaths that we made as healthcare workers. We've had to work longer hours with fewer resources, and we've been witness to and victims of structural violence and systemic failures in the global medical industrial complex. In addition to that, we've been on the front lines of this, which is really straining. Today, I want to speak to you briefly about moral injury, also abbreviated to MI. So for those of you who are not familiar with moral injury is described as the mental, emotional, and or spiritual distress that someone might experience following an event where they were forced to act or were unable to act in a way that transgresses their moral code. So basically, your morality becomes injured because you felt like you could not do what you believed to be right, or you were forced to do something that you felt was wrong. This concept was introduced to me in nursing school after I was sharing some feelings of guilt and grief that were left over from my involvement in humanitarian work in Greece, which is where I met Layla and Abdulaziz. I had also been working in Lebanon, and I was talking to an instructor about this, and she was studying moral injury in emergency room nurses for her PhD. So in my line of work, I focus on male forced migrants. They're usually undocumented, and so they have very little access to anything, if any access at all, to any sort of support. They're exploited, they're excluded from healthcare systems. Mental health is really on the back burner here. We're talking physiological health. So I provide male-specific sexual and reproductive health education and medical referrals. And then we also try to provide mental health support when there are opportunities to, or when someone's having an acute problem. So I also specialize in supporting communities. This has been mentioned a couple of times, but how important that community level intervention is for maintaining positive spaces for either promoting better mental health or for assisting people who are in mental health crisis. So every single encounter that I have within these communities, this offers a plethora of potentially morally injurious events, also called PMIs. And these are situations for me where my hands are tied and I'm forced to either make a bad decision that I feel like is the wrong one, or I'm unable to make the decision that I feel like is the right one, or I'm withheld from acting in the way that I know is right. So many of us in healthcare throughout this pandemic can think back to a situation where we encountered a PMI, whether you are a full-blown practitioner or you are a student, or you're interested in becoming a medical student or a nursing student. We can think of situations in our professional lives or personal lives where we had to make a decision that we felt like it still kind of haunts us to this day, where we felt like we made the wrong one. And that is moral injury. So trauma therapies are usually not effective for moral injury. While potentially traumatic events and potentially morally injurious events can occur simultaneously and symptoms and feelings can kind of overlap, it's really important for us to remember that the resulting feelings of a moral injury are really rooted in guilt and shame over that transgression of your morality, whereas trauma, the lingering feelings are usually fear-based. So with talk therapy, exposure therapies, hallucinogens, trauma can be treated and it can sometimes usually be resolved. So these pathways that create that trauma response, we can reroute those, which is really cool. And so that knee-jerk reaction when we're triggered, when our trauma is triggered, we can subdue that and people can go on and live a relatively normal, comfortable life. But what do we do when we experience an injury to our soul, spirit, and morality? And how do we mitigate these injuries that don't necessarily come from something passively happening to you, as is the case with a traumatic event, but a time where you were put in a difficult position because of structural violence and injustice, and you were unable to act in the way that you felt was right? I don't have a solid answer for that, and neither does the literature. MI is currently being studied by a lot of different sectors. We've got neuroscientists, community psychologists, psychiatrists, philosophers, and religious scholars. As was mentioned, I'm part of a research team that's studying this in medical workers, humanitarian workers in global health contexts. But we have come up with a few remedies. And this is something that I've been working on recently to sort of work through my own mental health problems. So remedies, these have included something as simple as adding moral injury to your vocabulary. And maybe that term really resonates with you if you haven't heard it before, but it's one of those things that we have a lot of different ways to talk about trauma and triggers, but when it comes to those residual feelings of guilt and shame, it can be really hard to express those to someone, and therefore it can be really hard to get help. This can also really help with your personal reflection using that vocabulary. And so things like journaling or discussing these feelings of guilt and shame with other people that you trust, ideally people who have experienced similarly morally injurious events to you, that can have really positive outcomes for people who are struggling with those feelings. Community reconciliation, where the burden of responsibility for the potentially morally injurious situation is shared at a community level. This has proven to be very helpful, especially in war veterans who are experiencing moral injury, which is where the term came from. I personally also find solace in pursuing justice and trying to reform these systems that created that state of structural violence and put me in that morally injurious situation to begin with. So going forward, moral injury is a concept that really needs to be explored, and I think it needs to be pulled to the forefront of the discussion about mental health. There's no age limit to moral injury. Anyone can experience this. I think the younger people are, and when they're not given this vocabulary to talk about these types of feelings, and we're not made aware that this type of injury exists, it will have really severe damages on adolescents or on younger people like me who have recently entered the healthcare sector and are continuously subjected to morally injurious situations. I also take that statement a step further and say that when we're talking about this concept of mental health, right, it's defined as psychological and emotional well-being. I think that a spiritual element really needs to be added here. And Farah said something that was really important, which was, part of her journey to healing her mental health included her relationship with God, with her spirituality. Morality is the thing that kind of creates society. It's what holds us together and weaves all of us together. And if that's injured, it really fractions our relationship with ourselves and our communities and the people around us who are there to support us. So the amount of moral injury that I incurred in my work in the last few years, especially in the pandemic as a medical provider for refugees, for people who are kind of bottom of the bucket for getting any sort of support whatsoever, my moral injury eventually led me to contemplating suicide because I felt like these feelings of guilt and shame were inescapable, and there were really no resources for how to work through those feelings. And I felt like I would never reach a point where I would be free from them. It accelerated my clinical burnout. Moral injury led me on a crazy, desperate search for remedies, which is where I came across this term in the research team. But none of these remedies really fall within the traditional Western-centric realm of what we consider to be mental health care. MI is not a chemical imbalance. It's not an overexcitable neural pathway. It's when your soul and spirit are wounded and to the point where your moral compass can no longer orient you. And this is a really distressing feeling for people. So I will just say that current and future generations of healthcare workers, as well as anyone who's subjected to morally injurious events, they deserve and desperately need ways to protect and heal their morality when these types of transgressions inevitably occur. Thank you.
Thank you so much, Maddie, for sharing your journey. I know that that's a journey that will resonate for a lot of healthcare workers around the world. It's been tough times for sure. So I'd like to move into a Q&A and invite our youth back for questions if you're able and willing. So I'm going to shift gears a minute. I know that social media has an important role that it can play in public health. And we've seen how it can connect people, often people who have a rare disease. It's a way to reach out to others and find community. But we also have data that it can be harmful, particularly for young women, but for youth in general. And so I'm just wondering if you could comment on what role social media has played in your life and in your work. Would you be willing to start us off, Farah?
Yeah, sure. I'd like to start with my initial days. I used to post pictures of myself, not showing my hands, because I was afraid of what people would say. I'd apply tons of filters on my pictures and post them, and that was my first initial interaction with social media. When I chose to share my story on a local TV show in an interview, and the response that I received, it was a lot of encouragement, a lot of love and support, and a lot of questions. And that made me wonder. It made me really, really confused. Maybe not confused, but it made me sit back and think that, wow, because there was this message, and I always share this because it really hit me. There was a message from a young girl. She had a small spot on her face, and she asked me, how are you so confident? And I was just shocked. I was like, what? You know, I am not even confident. I was sharing my story in the hopes of finding a cure. But I didn't know that I was being showed another path, that I could share my strength and his strength to others. And that made me realize there is so much of validation that we seek on social media. What we see on social media is not reality. It isn't. And that made me share myself even more. I was out there. I started posting full portrait pictures of myself, you know. I wasn't putting any more filters. I was like, this is me. This is how I look. And I am real. I own my real. And I want everyone to do that. I want all the girls to know that we are all different. I want young girls to know, to look at themselves in the mirror and look at their bodies and tell themselves that yes, I am different. I can't look like maybe Kim Kardashian. I can't look like Angelina Jolie, you know. I can't look like anyone, you know, that young girls look up to nowadays, because we can't. We're all different and we're all unique. And that is my message on social media. I want to spread a lot of appreciation for yourself. And social media has helped me spread my message far and wide. And being able to say it here on such a huge platform, truly grateful, truly honored. And I believe social media has that potential to really make a difference. I have seen it. Yeah.
Thank you. Thank you for sharing that. Do any of our other panelists want to comment on the role of social media in your journey? If you do, please come. Yes.
Hi. Yes, I think that Para is completely fantastic, and I agree with her. And in my journey as an advocate, social media has played such a big role, because where I am, one, it has helped to demystify some of the stigma around mental health by just showing people that everyone goes through something. But by speaking openly, like Farah said, you don't know who you're speaking to, but they know, and they reach out and they say, hey, I fully understand what you were speaking about because I went through that. It's a way to continue conversation and it's a way for young people to, you know, make the space for themselves and speak about issues that concern them. One of my favorite examples is TikTok. Very many people talk about disinformation on TikTok, but people have found family there. People have found understanding. People have found a way to cope just by looking at other people, just by, you know, embracing that other people as well are going through the things that they're going through. Yeah, thank you.
Thank you so much. Is there anyone else from the panel who would like to comment on this role of social media? Otherwise, I'll move on to one of the other questions in the chat. So I think, oh, great. Abdulaziz, please go ahead.
Yeah, I think it's a very hard thing anyway, because I think like social media today remind us all of what's happening. Like I think a lot of refugees today are stuck on social media, like what happened in Ukraine lately, what happened before that in Palestine, what happened before that in other countries. Every time we are stuck, like we are observing everything until it becomes tiring. It's like us going through the war again, going through all of that again. And social media plays a big role in that. Like I know that for myself, I speak for myself now. I know that I have to cut off every other ride, especially when things happen like that, because I can't go more, you know, like I can't follow up and I can't get more news. I feel I hit to a point that I'm just done. Like I'm following news the whole day. And so I think, yeah, social media in that sense can be very dangerous. I know a lot of people around me who suffer from that as well. Even people who were not even, you know, like who are not even Syrians, but or not even they don't have a war kind of background, or they don't have anything. Still, the amount of information that we get about so many different places, the amount of sadness and things we cannot change is tough to take. And it's, I think as humans, we weren't supposed to be exposed to all of that in the same time or in a very short time and all that information, but still that is happening, and social media does that a lot. So yeah, it can be tough. If people cannot control it, it can be really tough.
Yeah, it can be pretty overwhelming and re-traumatizing, I'm sure, for many people. Yeah. Thanks for sharing that. Maddie, did you want to make a comment about social media? I saw you come on camera for a moment.
Yeah, I mean, Abdulaziz really covered everything that I was going to say that I think is relevant here. But, you know, during the pandemic, I sort of noticed two big pros and cons to people really relying heavily on electronics and digital communication. One being, if that had happened 100 years ago when we didn't have these amazing ways to keep in touch, it would have had really severe consequences on people's mental health. But what I saw a lot of was people sort of creating these artificial realities in their social media space, which can be good and it can be bad. On one hand, it can be really empowering for people, like Farah and Grace shared some great examples of how you can find community in that. And you can also see people normalizing a variety of things, from body image issues to mental health problems. We see people normalizing their journey and sharing it, which is really cool and empowering. But it can also be really dangerous. And I think something that I really struggled with was sort of the gap between technological literacy between, you know, people who are, I'm like a young millennial, and so my generation and below, we were raised with technology. We know we're very fluent in it, but our parents or people who are supposed to be sort of helping us, role modeling for us and helping us navigate some of these issues that we talked about, they're not technologically fluent the same way that we are. And so there's an entire dimension that they're really absent from and that they're not able to understand, which, as Abdulaziz said, can sort of lead to issues when you don't know how to set those boundaries for yourself and you don't know how to filter what you're absorbing and process it appropriately and safely. It can really cause some problems. So good points by everyone and sort of the pros and cons of it.
Yeah, it can be a pretty tough issue. But again, a source of support, I think. There was a question in the chat about where have you found empathetic understanding of your experience and your interpersonal world? And obviously one place it sounded like from Farah that you found that it is through social media, but are there other avenues or sources of support that you found? And I'll just go ahead and ask, you know, how does that tie into your own sense of resilience?
I think my very first support system was my family. My mom is my pillar. She's been with me, you know, she's like the force behind me. She literally gets me out of bed in the morning when I don't want to. She removes the blanket and she's like, "You're going to get up today." You know, she literally brings me out. So my mom, my family, they've all been very supportive. They've really shown me that I can. They had included me in everything. They're not set me apart, you know, like shown me that I'm different and I can't do stuff or stuff like that. No, they've always been very encouraging. They've made me, you know, right in the center, you know, literally like, I know I can control stuff, you know, they have given me that power. They have given me that strength. Number two, I found strength and a lot of freedom when I started writing, when I discovered writing and blogging. I found, I don't know, I just felt good to write about stuff. I felt nice. And so I encouraged myself to do it. I never let it go. And recently I'm really into vlogging. So I'm always, you know, looking for stuff that I want to do. I love to create. So I'm always exploring stuff. I love tech. I'm always trying to explore new apps on the internet, new stuff, how to manage my time, how to do stuff. I'm always looking for something to do. And so I really agree with Abdulaziz as well. Social media can be dangerous, and I too take breaks from it. And it is so good when you take a break from social media. It's the best. But yeah, I do agree it can be a bit overwhelming, and it did for me as well in 2020 at the height of the pandemic. And yeah, that's a whole story for another day. But yes, that's my answer.
Thanks, Farah. I love your spirit of curiosity and learning. I think that's a lesson we can all take throughout our lives. Abdulaziz, do you want to comment on this? What's your source of support, and how do you stay resilient?
It's a tough question, actually. I think there are many things that plays a role. For example, in kind of believing. I think believing is one of the things that now that I said believing anyway, like to believe in the thing we're working for is always helping us to kind of keep going despite it's a hard condition. I think we can talk about that because just yesterday, no, yeah, actually not yesterday, but on the 15th of March, it was the 11th anniversary of the Syrian Revolution, which is 11 years. And unfortunately, nothing is changing. The same thing is going on. And for a lot of people, they do wonder until now, how come we're still fighting for the same thing we're fighting for since 11 years? We left our countries, we forcibly left our countries, hundreds of thousands of people were killed, and we're still going through the same condition. And the answer is that we believe it's what we're fighting for is our right. And our belief is actually what's giving us the resilience to keep going. Apart from that, hobbies are always helping. Like for me, for example, when I left Syria first, I found the power that I wanted to in art. So I started doing art because I wanted to imagine. I wanted to let my imagination take me to a different place than the place I was in. And through doing art, actually, I found that my energy, my negative thoughts were always put into a piece of art. And that helped me a lot. And apart from that, I was lucky to meet a lot of friends, including Maddie, including actually a lot of friends I met when I was in Greece, who were always also helping, listening, and trying to push us further, to push me further. And that is something I'm always thankful for.
Yeah. So belief and beauty, finding beauty in other things can really help sustain you. Maddie, did you want to say something about this? Resilience, support?
Yeah, I have to credit my therapist. I think we've done a lot of talk about mental health and no one has mentioned therapy yet. And for me, sort of working through my own things with a mental health professional for a very long time, I was reliant on my community and the people around me. And there are certainly some things that my therapist will simply never understand because she wasn't there. And that's when I really rely on people. As Abdulaziz said, we met in a camp that he was living in. And so he'll understand some of the things that I've seen and experienced in ways that people who weren't there simply won't. But getting that professional help is it's really, really important because therapy, I think, can be stigmatized as trying to sort of fix something that's broken or defective. And sometimes it is that. But more often than not, my therapist just gives me tools to look at my own things differently and to be more resilient moving forward. And she sort of, rather than fixing problems for me or even alongside me, she gives me the tools and the resources to do it myself, to reflect and to process and to protect myself from future mental health damage. And so I know that therapy is absolutely a privilege. Professional mental health support is not something that everyone can access. But for those of us who can, I think it's really important for us to go and do that work so that in some ways too, we don't become part of the problem as all of those people out in the world who do need therapy, who are then projecting all of our stuff onto other people and situations. And also, if it is your privilege, yeah, as Farah said, it's really inaccessible. It's really quite costly. And in a lot of parts of the world, I mean, it's not even available. Even if you can afford it, there's simply not enough practitioners. And I think Layla mentioned that in her presentation as well. And so then those of us who do have the privilege of accessing those things, we need to advocate so that other people have access to them as well.
Yeah, I'm really glad you bring that up because we talk a lot about formal mental health resources, and it isn't available in a lot of places, but I'm glad that that's been helpful for you and that you can share that with us. Grace, tell us a little bit about your sense of support and resilience. What keeps you going?
First of all, I don't want to go back to everything my colleagues have said. So I will say very briefly, family, friends, helping others. But I think the thing that keeps me going the most is I have so much belief in a good future for us all. And I think that drives me. I think that contrary to a lot of the news and the things that are happening, I fully and 100% believe that we can create a better world. And I think that I would like to contribute as much as I can to that. And that keeps me going. Thank you.
Thanks so much. Really appreciate that. So now I think we're going to move to a bit of a break, 5-minute break, and that'll give us an opportunity to come back and have more in-depth conversations in some breakout sessions. Okay, so I feel like it's a good time for us to make that transition. I'll see you all in 5 minutes at 41 minutes past the hour. Thanks. Okay, welcome back, everybody. I'm looking forward to being able to speak with you and speak in depth about some of the topics we heard about in our first two panels. Again, thank you to all of the speakers. We really appreciate you sharing your personal experiences as well as the data and actions that you've taken in your journeys. So now we're going to go to 3 different breakout groups. You can pick the group that you're in. When you get to your group, there will be a facilitator for each group that have been previously identified, and then each group will pick a rapporteur, and you can discuss the theme in your area. And then I'd like you to identify 3 main points that you like to bring back to the whole group. So group number 1 is maintaining mental health of self, family, and friends. And Terrell Carter will lead that group. The second group, how to support youth mental health in pediatrics. And I, Jana, will lead that group. And then the third group will be advocating for mental health in the global health landscape. And Maddie has generously agreed to lead that group. So again, the facilitator will let everybody know which group they've arrived in. Make sure you got to the one that you wanted to be in. Have a rapporteur identified, and then come back to share with everyone 3 action points from your group. Okay, and we'll have about 25 minutes for the group discussion. Welcome back, everybody. I hope you enjoyed the chance to have a smaller group discussion. I know in my group, it sort of felt like we were just getting started. There was a lot more we could have delved into, but I think it just gives us a flavor for how we're thinking about the salient points in supporting youth mental health. So I'd love to hear back from the groups that met and what some of the primary points are that came up for your group. The first group was on maintaining mental health of self, family, and friends. So Terrell, could you indicate who your rapporteur was? And if you could please unmute yourself and share some highlights.
Yeah, so I am actually the rapporteur. We had a very small group. And so I will report out on 3 main points that we discussed. And again, we were focused on thinking about maintaining mental health for self, family, and friends. One main point that we talked about that came out in our discussion was normalizing mental health is important in seeking care. and maintaining open relationships with family and friends. We felt like that we still have a long ways to go and all over the world in normalizing mental health, and that in some cases you may feel more comfortable talking openly about your mental health with your family and friends, but in some cases you may not. And so doing more work around normalizing is important. We also talked about how your mental health is similar to your physical health, and you're never really done. Even when you feel healthy, even when you are eating healthy and exercising, you have to keep going. And it's the same way with your mental health, and that even when you're feeling mentally healthy, you have to keep maintaining and giving attention to it. And so that's important for your own self maintenance. We also, all of the members of the group that we were a part of were based in the United States, and we discussed how, particularly in the US, we're such an individualist society, and this really puts a lot on you as an individual to maintain your own mental health. And maybe we don't have as much of a community reaction to people who are experiencing ill mental health. And so because we're like this, we really need to learn to love ourselves, and doing more work and self-reflection and looking towards inside ourselves to be able to support others also. And I'll close there.
Thanks so much, Terrell. Group 2 was looking at how to support youth mental health in pediatrics writ large, and Ann Berman was our rapporteur. So over to you, Dr. Berman.
Thanks very much. Yeah, we had a great group with mostly psychologists and people that work in mental health, which was exciting for me as a pediatrician, but also pharmacists. And the first point was to really try to work with new parents and babies about how mental health is important to infants and children, and how parents can help support mental health. Lots of people still don't know that toddlers and infants can be negatively affected by what's happening in their own lives and the lives of their parents. Secondly, to destigmatize mental health is still in many places in the world globally, as well as in the US. People don't see mental health problems or they see it as a curse. Sometimes they don't understand that bad behavior may spring from mental health strain and anxiety in kids. And that's mostly through community education. Everybody stressed teamwork. That means not only dealing with mental health professionals, but also medical professionals and schools and social work to work together to understand a child and the family, and also to have some kind of universal standardization of how we deal with youth mental health for all professionals. Finally, well, next to last, to develop centers in communities that are both accessible and affordable to give not only information, but treatment for mental health. It's a huge, huge need everywhere in the world. And finally, how do we use schools not only for education of children about mental health, but also to have the teachers and the administration in the school help to identify children who maybe will have mental health needs, and how to work not only with those students, but with their parents to help them support children's mental health.
Thank you so much. The third group was focused on advocating for mental health in the global health landscape writ large. Maddie, you were the leader of that group. Could you report back on some of the highlights from the rapporteur, or if that was you?
Yeah, actually, Farah is our rapporteur. So Farah, if you want to unmute yourself.
Yes, I'm ready.
And yes, differently abled people would absolutely be included in that. So take it away.
Thank you so much. All right, first of all, thanks to Maddie for taking care of us so well and guiding us into the discussion. So our 3 points are number one, to normalize sharing feelings, failing, and being empathetic towards other people. Teaching this to kids in schools would be very beneficial. Number 2, advocate for the support of parents, mothers in particular, because we know that healthy parents promote healthy development of infants at a crucial age. Number 3, decolonize mental health. This includes diversifying the research that is done on mental health to include refugees and people from various countries, cultures, and income levels, and to include differently able people. That's our point. Thank you so much.
Thank you, Farah. So I'm hoping that these conversations in your small groups spurred some ideas for you of action steps that you can take in your own work, in your own practice. And I would just invite you to take a few minutes now and put those into the chat box if you choose to share, and perhaps go one more step and take some of those action steps that came out of what you've heard and email them to yourself as a measure of self-accountability, so that when you come back to your desk tomorrow or whenever that may be, it's waiting for you in your inbox as something that you want to attend to, that you want to give energy and effort to. I think that for many of us, it's hard to sustain sometimes that dedication and commitment and forethought of those things that we want to work on, but it's easy to let it slip when other things pop up to the top of your inbox. So as we allow things to filter in through the chat box, we're going to also go to a break, and we will come back at 1:30 to hear from Dr. Zulfi Bhutta. And I encourage you to take these few extra minutes of reflection and time to formulate your own action steps to share with each other. So you have just a little over 10 minutes for that reflection and for your break. Okay, let's all come back together now. It is my pleasure to introduce our keynote speaker today, Dr. Zulfikar Bhutta. Dr. Bhutta is the Robert Harding Inaugural Chair in Global Child Health at the Hospital for Sick Children in Toronto. He's also the co-director of the Sick Kids Center for Global Child Health and the founding director of the Center of Excellence in Women and Child Health at the Aga Khan University in Pakistan. His resume is long. His publications could form a hardbound journal. But I did have the pleasure of traveling with Dr. Bhutta in rural Pakistan several years ago. And one of the things that struck me about that experience was that we came into a small town, and a mother and her child had been waiting because they heard there was going to be some doctors coming. And Dr. Bhutta, many don't know that he actually originally trained as a neonatologist. Dr. Bhutta came out to examine the child who had a blistering disease of the skin. And it was in that moment that I recognized why so many people had been touched by Dr. Bhutta's efforts for so many years, and that the compassion and the care that he showed to this child and to this mother who was seeking an answer for the diagnosis of what was wrong with her child and the blistering skin disease. And of course, he knew right away what it was. And of course, I, as a neonatologist, had to go and look it up. But that moment stuck with me. And I am pleased today that he's able to join us to talk now about mental health of children and adolescents during COVID. Because of course, he could talk on many topics, but we're glad you're here to join us, Zulfi. Over to you, Dr. Bhutta.
Thank you very much, Dana, for that generous introduction. And it's been a pleasure over the years to work with you in a variety of settings. So I'm not by any means a psychiatrist or a mental health specialist. I've been forced into some of these topics because of the nature of our work over the last few years and our interest in how COVID-19 has affected the lives of many across the world and also across socioeconomic strata. So over the next 20 minutes or so, what I've been asked to share with you is just a broad overview, largely a personal perspective on the issues of mental health in children and adolescents living in these times. What I will do is to share with you some thoughts on global burden, and you might have heard some of this over the whole course of today's symposium, talk a little bit about risk factors and critical periods. I'll share some of our thoughts on the mitigation strategies and their potential impact across the world, particularly in low and middle income countries in South Asia. And I like to finish by some room for optimism around what can be done and what are the implications for global policy. So I won't say much about the global burden, except to say that we all recognize that the current knowledge of the burden of mental health disorders in particularly children and adolescents is still evolving. It's evolving because much of the information that we have on this is from high-income countries and some upper middle-income countries where there is better documentation. And the fact that there are many parts of the world where you have comparatively lower prevalence of this disorder is largely a reflection of potential underestimation. And this has been shown recently by some elegant work by Rifat Khatun's team at Harvard and other colleagues, indicating that our potential underestimation of global burden on mental health might be as high as 30%. But be that as it may, if you look at the spectrum of what we know, particularly at the lower end of this etiological map of mental health disorders across the age bands, you'll recognize that although these appear smaller, but they contain many disorders that we recognize as major drivers of mental health and adversity in adult life. Depressive disorders, anxiety disorders, schizophrenia. They're a bit more difficult to diagnose when you're very young, but some of those risk factors are very much there. And therefore, our understanding of particularly screening and recognition of many of these disorders in children and adolescents is evolving. We know in numeric terms that these are not insubstantial across the world, and there have been various estimates, but there are also recognized issues with diagnosis, and misdiagnosed or undiagnosed mental health disorders I've already mentioned is something that particularly is likely in the younger age brackets where screening and recognition is a bit more difficult. We do know, however, that of the various mental health disorders in children, this is a graphic that shows you the prevalence of global DALYs for mental health across 0 to 19 age group. And you will see the preponderance of these are anxiety disorders, conduct disorders, and as you get towards older children, depressive disorders. And you will see that their distribution also varies across various parts of the world. But what I wanted to point out is that in this stacked bar of diagnoses across various global geographies, if you take the total population of Asia and Africa, which is these bottom two bands, it's very clear that there is largely an underdiagnosis there. And therefore, in relative proportionate terms, it appears that maybe this is not an issue with many of these large diagnostic bands for mental health in those areas. So I am willing to bet that over the next few decades, our knowledge, our data on the etiology as well as distribution pattern of mental health in many parts of the world will improve and grow. And we might get a false sense of rising incidence and prevalence just because our current estimates are so inaccurate and they are not being captured by real life health information systems. Whatever information we have over the last decade or so does suggest that across various regions of the world, if you look at the prevalence rates of various disorders, be those anxiety, bipolar disorders, depressive disorders, there isn't really massive change. If anything, we're getting slightly better at diagnosing them, and you see the slope of many of these lines is upwards. And we will, however, notice that this will change over time in many low and middle income countries as better diagnostic strategies get put in place. But to the average audience, it's important to recognize also the age transition of mental health disorders. So you do have a change in the pattern of mental health disorders as you go from the under 5 to the school age population, 5 to 10, a reduction in attention deficit or hyperactivity disorders as being the dominant diagnostic, and an increase in the recognition of depressive and anxiety disorders over time. And by the time you get to late adolescence, depressive disorders largely predominate. I've been trying to, for the last several years, trying to see how people fit suicide and parasuicidal behaviors as part of mental health spectrum. And it's been very difficult to put that in place because the current GBD does not accord that the same categorization as you have for many of the other diagnostic categories. A word or two about risk factors. We do know certain risk factors and drivers that have to relate to early exposures, adverse exposures, birth injury, family history, the prevalence of chronic medical illness or mental disabilities in the family. But there is also the recognition of the environment. So things like early exposures, and as was mentioned this morning, adverse early childhood exposures, particularly in geographies where those things are related to the environment that you live in or the environment that you are exposed to. And we'll talk about that briefly. But it's important to recognize this as a spectrum of changing risks and drivers over time. And they are reflected in the change that you see in terms of both mitigation measures, protective measures, and also social determinants that drive whether or not you will have the full expression of the phenotype of the risk factor and exposure into mental health disorders. And I like this graphic because it tells you clearly how over the period of time, any of these also reflect the opportunity for mitigation, for principally putting in preventive and promotive strategies that can impact the full-blown depiction of the disorder over time. So it's important to recognize this as a continuum. The consequences of some of these exposures can be lifelong and perhaps potentially intergenerational. These sensitive periods in early life that we all recognize as being so important for nurturing care and development are also sensitive periods where you can have adverse consequences also. And we now know that some of these impacts earlier on can lead to epigenetic changes, disruption, reprogramming of your stress pathways and immune regulatory pathways that can impact adult outcomes in many ways. It can not only lead to increased risk of deficits and impaired adult outcomes that you and I recognize as being consequences of mental health issues, but there can also be risks for other non-communicable diseases. And what is underappreciated is the relationship of this early conundrum of mental health disorders with non-communicable diseases of the other kind, strokes, heart failure in later life. And this association is something that we are only just beginning to recognize. And it's much worse and long-term for children and family in conflict settings and in displaced populations, areas of my interest and work, where we work in those geographies. So I don't have to tell this particular audience how important it is to recognize the number of children who are affected in the current conflict and insecure populations across the world. Our attention is currently focused on Ukraine and the enormous tragedy that's unfolding before our own eyes. And many have already forgotten the millions who are living in Afghanistan and who are now off the radar screen and off the daily news. Why? Because our attention has shifted. But remember, at any one given point in time, roughly about 40% of all the world's displaced people are children. And many of them are orphans. And certainly with COVID-19, the recognition that orphanhood has accompanied this tragedy across the world with a 6 million plus deaths that we have, and that many of those lives have been disrupted for a long time and with potential intergenerational consequences. So this is my last graphic showing you how the relationship of early trauma, that can be just at a family level, but it can also be through exposure to violence and conflict, poverty, extreme poverty, trafficking, sexual and physical abuse that comes as part of this, unfortunately, in many parts of the world, displacement, social, all of these can kick in and make an propensity for adverse consequences of early mental health and toxic exposures much worse over time. And some of these effects are intergenerational. So we should not be underestimating the potential impact on society of mental health disorders. Now, COVID has been a major disruptor. I don't have to tell this audience that this is a pandemic that has turned the world upside down, with over nearly 460 million cases and over 6 million deaths, which are probably an underestimate, no part of the world has been left untouched. Now, but the one thing that we do know is that it relatively spared children from the direct effects of COVID. This graphic illustrates how, in terms of cases and also mortality, children were spared the worst aspect. There were cases, definitely, but they were spared the worst aspects of some of the COVID-associated mortality. Those figures have been generally less than 1%. They increase as you go along adolescence and older age, but there is a recognition that this is not a pandemic that's had a direct effect on children. But the indirect effects have been huge. In fact, my own interest in COVID and the reason why I set up a working group very early on in the course of the pandemic in the year 2000 was largely driven by this UNICEF report that came out in March 2020. And it made a few statements that still stand out as startling at that time and prescient in many ways, because it said the children may not be the face of the pandemic, but the risk being its biggest victims. Their lives may be changed in profound ways. Now, one of those factors that has driven some of the impact of COVID on children has been school closures, something that I've been tracking very closely from the very beginning. So school closures were just kicking in when the pandemic was declared, but they became also almost universal by the summer of 2020. And you will notice over time that it took a long time for the world to actually relax and start to consider and begin opening schools. And then it became political. And it became very difficult to do so in many other parts of the world. And even today, as we speak, in the middle of March, there are many countries where school closures are still fairly widespread, and they've been largely affecting the poorest of the poor. Now, our working group looked at a number of these issues through the lens of what could be the consequences of these COVID mitigation strategies, not just school closures, but also lockdowns, the food insecurity, and also poverty permeation. But we were particularly interested in looking at what could happen through school closures on mental health and outcomes. And these could be just not only because of school closure, but also the indirect impact that it has on early marriage. And I'll share some of those examples with you in a moment. But let's first look at what is the evidence of the impact of COVID-19 on mental health outcomes in children and adolescents. We have just recently finished a systematic review. Actually, it's turned out to be a review of reviews because there are so many reviews now available on the subject. And here in this particular exercise, we have looked at 17 systematic reviews very recently, which are robust and looked at over 350 unique primary studies. And a slight overlap in some areas, when by and large, these reviews related to the Americas, Europe, and Western Pacific, very few from low and middle income countries. Not very surprising. This is a busy graphic, but it tells you how we have tried to summarize the data over time. And what you can see is that for two of the disorders that I will mention to you, depression being one, there's almost a 1/3 increase in depression in children during COVID-19 across a range of geographies. For anxiety, you're also looking at something close to a 1/4 increase. Some of the best analyses on this have come out of Russell Weiner's group. And here, what he looks at is whether or not income inequality and access to hybrid schooling or remote schooling matter. And what you see in this graphic is that if you had in-person schooling across age, your difficulty score, which is the standard strengths and difficulties questionnaire administered to parents, goes down. But contrast that with those who had remote schooling. So if you just compare adolescents here, world of a difference between children who had difficulties, who had remote schooling, versus those who had the opportunity of a hybrid system. And this was also very evident across socioeconomic strata. So if you came from a high income situation, in-person schools were far, far more protective as compared to others. And you do not see that same protection in poor populations where most of the children did not have access to schooling in the traditional way. And his estimation in terms of the impact on mental health composites here shows exactly the same, that there was a significant increase, particularly in difficulties in remote schooling, and also by poverty gradients, by populations which did not have access to mitigation measures and did not have access to other forms of support. Now, in the context of South Asia, we looked at this in some detail, and I don't have time to go through what happened in the health system, but clearly a lot of the protection and a lot of the interventions that were available within the traditional health system went down. And this is really DHIS services for women and children and adolescents over time. And you can see much of that recovery did not take place right until the second or third quarter of 2021. But the important thing to recognize is that a lot happened outside of the health system. So we believe 420 million school-age children in South Asia have been out of school since March 2020. And this has not only led to a tremendous loss in educational achievement, but around 9 to 10 million children would have dropped out of school completely, not only causing a huge loss to the national exchequer, but in my book, a tremendous loss and impact by the number of girls who have had to get into early marriage because they really did not have schooling. And our estimations for that are enormous. About 4.5 million girls have dropped out, and we estimate that they have translated into close to around 450,000 unwanted adolescent pregnancies. Now, if you work out through models, LifeSafe Tool model being one of them, the consequences in terms of the next generation, adolescent pregnancies, maternal, newborn, outcomes, excess low birth weight and stunting, those numbers are huge across South Asia. So sadly, this has happened. And this impact of COVID has been almost universal across the world, particularly in low and middle income settings. And this disruption that I've mentioned of health systems and support has also impacted considerably whatever little was available in terms of counseling, psychotherapy, or mental health interventions. And we've seen this even even here in North America and Canada, where I'm speaking to you from, many of these services were completely disrupted. And while the rich had access to some kind of redress with services like telemedicine or teletherapy, this was generally not available to the poor, particularly those living in urban slum populations. I want to underscore that in a recent assessment, while now there is much greater awareness of mental health as an issue across the world, and it's very much recognized to be there and be included in the SDGs, there is just no money for it right now. Very little resources, and only about 17% of countries said that they had additional funding for this. So what can be done? So let me finish by saying that we believe that a number of mitigation strategies, prevention, better treatment, and better aftercare are possible. And some of these certainly can be put in place across the life course, looking at not only young children, school-age children, and adolescents. And to look at this, we've recently undertaken a systematic review of what are feasible interventions across the life course, but also looking at various delivery platforms. And I heard some of you talk about schools as being a platform for intervention, and we believe that is indeed the case. And it's a new platform that we need to develop in the context of low and middle income countries. But there are also delivery strategies possible through community settings, through health workers, outreach workers, and using the power of the emerging power of digital or social media, even in low and middle income countries. So we have undertaken a systematic review of what is available, and this will be soon published as a full supplement in Pediatrics around interventions for school-age children. The supplement will come out on I believe, the 2nd of May. And in the mental health arena, we have looked at close to around 250 different studies. And I can summarize those in just these 3 bullet points. First of all, much of the evidence is from high and middle income countries. And the strongest evidence we have of what works for mental health is for school-based universal interventions include anti-bullying strategies. We have moderate evidence of impact for substance abuse prevention, early learning, and positive development interventions in mixed settings. Some of the interventions that we have in low and middle income countries are focused on under 5 children, not really beyond. So in low and middle income countries, the only promising intervention that we found for which there was evidence in the literature was from youth development programs. So we believe that a range of these interventions that everybody talks about that can be linked to what we are doing for women and young children have great potential for being used for mental health interventions. They include social safety nets, cash transfers, early nutrition and nurturing care, the same concept being transferred across age groups, the use of community health workers and outreach workers that have been used for improved maternal and child outcomes in low and middle income countries, and absolutely every intervention possible for keeping girls in schools and integrating some of these interventions with existing health interventions. This will require political commitment, and this will require acting early and acting at scale. And this will require money. I've already talked about how money is scarce at the moment and might even become scarcer with the crisis that we have in Europe. But the important thing to recognize is that this is not an expense. This is actually an investment. And for every dollar spent on evidence-based intervention for mental health, the return is around 5-fold, and maybe even greater if you take it across a life course and intergenerational impact. So I'd like to leave you with a graphic that I hope everybody will recognize very soon, because it is the graphic that we are using for our Lancet integration series, looking at child health across the entire continuum of 0 to 20. It comes out on the 28th of April. And it underscores the importance of the continuum of not only interventions across childhood, but how you could use the nurturing care principles of supporting health, nutrition, safety, security, learning, and positive nurturant relationships throughout this course of childhood. And the importance of the milieu or the environment, where we need to have protection of children through investments in our environment, in our climate change, in our social, political, and economic policies. Let me stop and thank you at this, and I'll be happy to answer questions, Jana, if there are any.
Thank you so much, Sophie. We didn't have any question pop up in the chat, so I'm going to take my prerogative to give you one hard one.
Oh.
So if you had the opportunity to address a large conference of ministers of health and ministers of education at the UN General Assembly, and they said, you know, you've given us such a comprehensive matrix of all the things that are important. We are aware of epigenetic changes. We know that COVID has negatively impacted children, but how do we prioritize? What would you advise them to prioritize across health systems to benefit children?
Oh, health system. So I was going to say that if I was to prioritize anything, I would tell them they need to make the investment in the education system. And for children who have lost a precious 2 years of schooling, adequate schooling, doing whatever we can to make up and ensuring that in the next pandemic, we do everything possible to make sure that schools don't get closed. There was absolutely no epidemiological basis for closing schools. We have that evidence from the very beginning that the children that we pushed out of school were the children at least risk of any adverse consequences, and their impact on the community was also very little. So in terms of investments, Jana, if you were to rebuild health systems, one thing that I would say is that the so-called missing middle needs to be bridged. I think for long, the big surprise that people had with COVID was how much we had ignored the school age population of children and how surprised we were that they were getting into problems that they got into, whether they were nutrition, whether they were ill health, whether they were mental health issues. And if you step back like I did and said, I want to have a look at what's known and what can be done and what is known in poor, low middle income countries about interventions for school-age children, I was shocked to find that there was virtually nothing. Nobody was interested in it because throughout the Millennium Development Goal period, all we focused on was the under 5 children, and that also the very young. And then we discovered adolescence, so we made the jump from under 5 to adolescent, and that also late adolescence, 15 to 19. So this whole gap in the middle is where there is tremendous potential for intervention, not for survival only, but for the very principles of sustainable development goals of focusing on quality of life, on thriving, on long-term outcomes, on health as a holistic whole. So I think we have an opportunity now, particularly using the nurturing care framework that I just mentioned, of ensuring that as parents, we look upon children the world's children the same way as we look upon our children. We don't dichotomize our interventions for our own children and our care as packets that we did when they were very young, and then we suddenly discover they are teenagers. It is a continuum that has to go across the health and education system in its totality.
I'm going to just pull one question from the chat. Do you have any specific suggestions for interventions or prioritization or programs for people who are differently abled, who are facing particular physical or mental challenges?
I think particularly with disability being such an under-recognized issue, absolutely. Starting with things that we can do for people with limited abilities, whether they are vision, whether they are hearing. We'll have our Lancet Commission's report out on people with hearing deficit, on children with hearing difficulties. And you can imagine how absolutely impossible was it for them during COVID, especially with everybody wearing masks, that they had just no ability to interact with people. So I think just being aware, being conscious of the needs of those children would be extremely important. And I would start with just focusing on things that every place should do: improving access, improving facilities and ability for special people and children to partake of learning. We tend to, sadly, I must say, equate disability and handicap, particularly physical handicaps, with mental health issues of things like mental retardation. And that is a tragedy that in our health and education systems should not be allowed to happen. And even if there are special needs, those needs need to be met. So I would say there is an opportunity there for incremental gains. Start with things like access, ability to access resources, and also how our strategies for meeting the needs of these children can be adjusted during times of crisis so they are not forgotten.
Thank you. Thank you so much, Zulfi. It's a pleasure as always. And thank you to all of you for sticking with us through this long workshop and session. I really appreciate your engagement and participation. And I'm glad that we were able to hear such a variety of voices. Wishing you all the best. Take care, everyone.